Scleroderma, also known as systemic sclerosis, can present with a wide range of symptoms that may mimic other conditions. Some of these mimics include 1. Systemic lupus erythematosus, SLE. Both conditions can present with skin changes, Raynaud's phenomenon, and systemic involvement such as kidney or lung disease. 2. Dermatomyositis. Like scleroderma, dermatomyositis can present with skin involvement, including rashes and muscle weakness, making it a potential mimic. 3. Mixed connective tissue disease, MCTD. This condition shares features with scleroderma, SLE, and polymyositis, often with overlapping symptoms, including Raynaud's phenomenon and skin involvement. 4. Eosinophilic fasciitis. This condition can present with thickening of the skin and subcutaneous tissues, similar to scleroderma, but without internal organ involvement. 5. Primary biliary cirrhosis, PBC. PBC can cause scleroderma-like changes in the skin, particularly in the hands, as well as fatigue and liver involvement. 6. Lichen sclerosis. This skin condition can lead to sclerosis of the skin, primarily affecting the genital area, and may be confused with localized scleroderma, morphea. 7. Hypothyroidism. Severe hypothyroidism can cause skin thickening and puffiness, myxedema, which can mimic the skin changes seen in scleroderma. 8. Nephrogenic systemic fibrosis, NSF. This is a rare condition seen in patients with kidney disease, where the skin becomes thickened and fibrotic, resembling scleroderma. 9. Chronic graft versus host disease, GVHD. Following bone marrow transplantation, chronic GVHD can cause skin tightening and fibrosis similar to scleroderma. 10. Sarcoidosis. This granulomatous disease can involve the skin and internal organs in a way that resembles scleroderma. Because scleroderma can affect multiple systems, careful clinical evaluation, along with appropriate laboratory and imaging studies, is essential for accurate diagnosis and to differentiate it from these mimics. Eosinophilic fasciitis, EF, also known as Schulman syndrome, is a rare inflammatory condition that affects the fascia, the connective tissue surrounding muscles. Unlike systemic sclerosis, scleroderma, EF typically lacks internal organ involvement and is more confined to the skin and subcutaneous tissues. Here are more detailed aspects of the condition. 1. Pathophysiology. Inflammation of the fascia. The key feature of EF is inflammation and thickening of the fascia. Eosinophils, a type of white blood cell, are often found in the affected tissues, which is reflected in the condition's name. Autoimmune component. The exact cause of EF is unknown, but it is thought to be an autoimmune process. It has been associated with immune system dysregulation and may be triggered by trauma, strenuous exercise, infections, or certain medications. 2. Clinical features. Symmetrical skin thickening. EF typically presents with symmetrical, painful swelling and thickening of the skin and subcutaneous tissues, especially on the forearms, arms, and legs. The skin may have an orange peel or peau d'orange appearance due to tethering to the underlying fascia. Progression to stiffness. Over time, the skin becomes hardened, leading to limited range of motion in the affected areas. Unlike scleroderma, EF does not usually affect the fingers or toes, no sclerodactyly. Peripheral eosinophilia. Many patients have elevated levels of eosinophils in their blood, which can be a clue to diagnosis. However, not all patients will have this finding. 3. Diagnosis. Biopsy. A deep skin biopsy that includes fascia is essential for diagnosing EF. The biopsy typically shows inflammation, thickening, and fibrosis of the fascia, along with infiltration of eosinophils and other inflammatory cells. MRI. Magnetic resonance imaging, MRI, can be useful in showing inflammation and thickening of the fascia and helps in distinguishing EF from other conditions like scleroderma or myositis. Blood tests. Besides eosinophilia, other blood tests may show elevated inflammatory markers, e.g. ESR, CRP, but autoantibodies typical of systemic sclerosis, e.g. ANA, SKEL70, are usually absent. 4. Differential diagnosis. EF can be confused with other conditions that cause skin thickening, including systemic sclerosis, scleroderma. EF lacks the internal organ involvement and Raynaud's phenomenon seen in scleroderma. Nephrogenic systemic fibrosis, NSF. Seen in patients with kidney disease, NSF also causes skin thickening, but has a different etiology and presentation. Dermatomyositis. EF typically lacks the muscle weakness and rash associated with dermatomyositis. Number 5. Treatment. Corticosteroids. High-dose corticosteroids are the mainstay of treatment and are usually effective in reducing inflammation and skin thickening. They are often required for an extended period to prevent relapses. Immunosuppressants. In cases where corticosteroids alone are insufficient, or if there are significant side effects, other immunosuppressive agents like methotrexate, azathioprine, or mycophenolate mofetil may be used. Physical therapy. Given the risk of joint stiffness and contractures, physical therapy is essential in maintaining range of motion and preventing disability. 6. Prognosis. Variable course. The course of EF can be variable, with some patients experiencing spontaneous remission after months or years, while others may have a more chronic or relapsing course. No organ involvement. Unlike systemic sclerosis, EF generally does not involve internal organs, and most patients do not develop serious systemic complications. 7. Epideme. Rare condition. EF is rare, with no known racial or ethnic predilection. It can affect both men and women, typically between the ages of 30 and 60, although cases in children have been reported. 8. Exercise and trauma. There is a noted association between EF and recent physical exertion, trauma, or surgery. Some cases may be triggered by these events, although this is not universally the case. Eosinophilic fasciitis is an important condition to consider in patients presenting with skin thickening and limb swelling, particularly when systemic features of scleroderma are absent. Early diagnosis and treatment are key to preventing long-term complications. Lichen sclerosus LS is a chronic inflammatory skin condition that primarily affects the genital and perianal regions, though it can also occur on other parts of the body. It predominantly affects women, but men and children can also develop the disease. LS can cause significant discomfort and may have long-term consequences if left untreated. 1. Pathophysiology, autoimmune component. Although the exact cause of LS is unknown, it is thought to have an autoimmune component. Many patients with LS also have other autoimmune diseases, such as thyroid disease. Hormonal factors. There is a hypothesis that hormonal factors, particularly a decrease in estrogen, may play a role, especially in postmenopausal women. Genetic predisposition. A genetic predisposition to developing LS is also suspected, as it tends to run in families. 2. Clinical features. Common locations. Genital and perianal areas. LS most commonly affects the vulva in women and the foreskin and glands of the penis in men. The perianal area is often involved, and the disease can create a figure 8 or hourglass pattern around the genital and anal regions. Extragenital sites. LS can also occur on the trunk, breasts, and upper arms, although this is less common. Skin changes. White patches. LS presents with white, shiny patches on the affected skin. These patches can be thin, fragile, and prone to tearing, leading to bleeding or erosions. Itching and discomfort. Intense itching, pain, and discomfort are common symptoms, particularly in the genital area. Scarring and atrophy. Over time, LS can lead to scarring and atrophy of the skin. In women, this may cause narrowing of the vaginal opening, while in men, it may lead to phimosis, tightening of the foreskin, or difficulty retracting the foreskin. Fissures and erosions. The fragility of the affected skin can lead to painful fissures, cracks, and erosions, especially during intercourse or with bowel movements. And 3. Complications. Sexual dysfunction. In women, scarring and narrowing of the vaginal opening can lead to painful intercourse, dyspareunia. Men may experience difficulty with erections or pain during sexual activity due to phimosis or other changes. Urinary problems. In severe cases, scarring and atrophy can affect the urethra, leading to difficulty urinating or recurrent urinary tract infections, UTIs. Increased risk of skin cancer. Chronic LS, particularly in the genital area, can increase the risk of developing squamous cell carcinoma, SCC. This risk highlights the importance of regular follow-up and monitoring. 4. Diagnosis. Clinical examination. LS is often diagnosed based on the characteristic appearance of the skin during a physical exam. The white patches, atrophy, and potential scarring in typical locations are suggestive of LS. Biopsy. A skin biopsy can confirm the diagnosis, particularly if the appearance is atypical or if there is a concern about malignancy. The biopsy typically shows thinning of the epidermis, a loss of the normal skin structure, and inflammation. 5. Differential diagnosis. Lichen sclerosis can be mistaken for other dermatologic conditions, particularly those affecting the genital area. Lichen planus. This condition can also cause white patches in the genital area, but it often has a different distribution and may affect the mucous membranes, such as inside the mouth. Vulvar intraepithelial neoplasia, VIN. VIN presents with vulvar lesions that may mimic LS, but it represents precancerous changes in the vulvar epithelium. Atrophic vaginitis. In postmenopausal women, atrophic vaginitis can cause thinning of the vaginal lining and discomfort, which may resemble LS. 6. Treatment. Topical corticosteroids. High-potency topical corticosteroids, such as clobetasol propionate, are the first-line treatment for LS. They are effective in reducing inflammation, itching, and preventing progression. Long-term, intermittent use may be necessary to prevent recurrences. Topical calcineurin inhibitors. For patients who do not respond to corticosteroids or who have side effects from prolonged use, topical calcineurin inhibitors like tacrolimus or pimecrolimus may be an option. Emollients. Regular use of emollients can help keep the skin moisturized and reduce symptoms, especially for maintenance therapy. Surgery. In cases of severe scarring or structural changes, e.g. phimosis in men, surgical intervention may be required. Circumcision can be curative in men with foreskin involvement. 7. Prognosis, chronic condition. LS is a chronic condition, and while treatment can control symptoms and prevent progression, it is not curable. Many patients require long-term follow-up and intermittent treatment to manage flares. Cancer surveillance. Due to the increased risk of squamous cell carcinoma, regular monitoring is necessary for patients with genital LS. Any new lesions, ulcerations, or areas of persistent discomfort should be biopsied to rule out malignancy. 8. Epidemiology. More common in women. LS is more common in women, particularly those who are postmenopausal, but it can occur in men and children as well. Bimodal age distribution. The condition tends to have a bimodal distribution, with peaks in prepubertal girls and postmenopausal women. In men, it is most commonly seen in uncircumcised individuals. 9. Triggers and risk factors. Hormonal changes. Decreased estrogen levels in postmenopausal women may trigger LS, though this is not definitive. Trauma. Koebner phenomenon. LS may be triggered or exacerbated by trauma or friction to the affected areas, such as rubbing or scratching. Lichen sclerosis is a manageable condition with appropriate treatment, but early recognition and intervention are key to preventing complications, particularly in the genital area. Scleromexedema is a rare, chronic, and progressive skin disorder that belongs to the family of cutaneous mucinoses. It is characterized by the deposition of mucin, a gel-like substance in the skin, along with fibrosis and proliferation of fibroblasts. Unlike localized forms of mucinosis, scleromexedema involves systemic manifestations and is often associated with a monoclonal gammopathy, an abnormal protein produced by plasma cells. 1. Pathophysiology. Mucin deposition and fibrosis. The hallmark of scleromexedema is the excessive production of mucin by fibroblasts in the skin and connective tissues. This mucin is deposited in the dermis, leading to thickening and hardening of the skin. Monoclonal gammopathy. More than 80% of patients with scleromexedema have an associated monoclonal gammopathy, typically IgG lambda. Although it is not entirely understood how the gammopathy contributes to the disease, it is believed to play a role in the disease's pathogenesis. 2. Clinical features. Skin changes. Waxy papules. Scleromexedema presents with numerous small, firm, waxy papules, typically 2 to 3 millimeters in diameter, that are distributed symmetrically. These papules coalesce into plaques, giving the skin a bumpy, indurated appearance. Thickening of the skin. The skin becomes thickened and hard, resembling the skin changes seen in scleroderma. This can lead to restricted movement, especially in the hands, face, and neck. Sclerodermoid changes. In some cases, the skin changes can mimic those seen in scleroderma, including tightening and hardening of the skin, particularly on the face, neck, and extremities. Facial changes. Leonine facies. The involvement of facial skin may lead to a characteristic appearance known as leonine facies, where the facial features become coarse and thickened. Expressionless face. Due to skin thickening and hardening, patients may develop a mask-like face with reduced facial expression. Systemic involvement. Musculoskeletal system. Patients may experience joint stiffness, myopathy, and contractures, particularly in the hands and wrists. Neurological symptoms. Neurological involvement can occur, including peripheral neuropathy, seizures, and encephalopathy. In some cases, a potentially fatal condition called dermatoneurosyndrome may develop, characterized by fever, altered mental status, and coma. Cardiovascular and pulmonary systems. Cardiac involvement, e.g., cardiomyopathy, and pulmonary fibrosis can also occur in scleromyxedema, although these are less common. 3. Diagnosis, skin biopsy. The diagnosis of scleromyxedema is confirmed through a skin biopsy. The biopsy typically shows mucin deposition in the dermis, increased fibroblasts, and fibrosis. The presence of mucin can be highlighted by special stains, such as Alcyon blue. Laboratory tests. Most patients with scleromyxedema have an associated monoclonal gammopathy, which can be detected by serum protein electrophoresis, SPEP, or immunofixation. Other laboratory findings may include elevated ESR, CRP, and paraprotein levels. Imaging and electromyography. If systemic involvement is suspected, imaging studies, e.g., chest x-rays for lung involvement, echocardiography for heart involvement, and electromyography for myopathy, may be indicated. Factor 4. Differential diagnosis. Scleromyxedema must be differentiated from other diseases that cause skin thickening and mucin deposition, including scleroderma. While both conditions cause skin thickening, scleromyxedema is associated with mucin deposition and a monoclonal gammopathy, while scleroderma involves autoantibodies and significant internal organ involvement. Scleroderma. Another cutaneous mucinosis, scleroderma presents with skin thickening, but lacks the waxy papules seen in scleromyxedema and is often associated with diabetes or infections. Lichen myxedematosus, papular mucinosis. This is a localized form of cutaneous mucinosis, typically without systemic involvement or monoclonal gammopathy. HAV5. Treatment. Challenges in treatment. Scleromyxedema is a difficult-to-treat condition with no standardized therapy. Treatment is aimed at reducing mucin deposition, controlling systemic symptoms, and managing any associated monoclonal gammopathy. First-line therapies. Intravenous immunoglobulin, IVIG. IVIG is often the treatment of choice and has been reported to improve both skin and systemic symptoms. It can lead to long-term remission in some cases. Corticosteroids. Systemic corticosteroids can reduce inflammation and may be used in combination with other therapies, although they are not curative. Other therapeutic options. Plasmapheresis. This can be used in cases of severe systemic involvement or dermatoneurosyndrome, especially when related to the monoclonal gammopathy. Thalidomide and lenalidomide. These immunomodulatory drugs have been used successfully in some cases, particularly when there is an associated paraproteinemia. Autologous stem cell transplantation. For refractory or severe cases, autologous stem cell transplantation has been reported to induce remission. Chemotherapy. In cases with significant monoclonal gammopathy or progression to multiple myeloma, chemotherapy may be considered. 6. Prognosis. Chronic and progressive. Scleromyxedema is generally a chronic condition with a progressive course. The prognosis depends on the severity of systemic involvement and the response to treatment. Potential for remission. Some patients achieve remission, particularly with IVIG or other systemic therapies, though relapses are common. Mortality. Mortality can occur, especially in cases with severe systemic involvement, such as dermatoneurosyndrome, cardiac involvement, or progression to hematologic malignancies like multiple myeloma. 7. Epidemiology. Rare condition. Scleromyxedema is extremely rare, with only a few hundred cases reported worldwide. It typically affects adults in midlife with no clear gender predilection. 8. Complications. Dermatoneurosyndrome. This is a severe, life-threatening complication characterized by fever, confusion, seizures, and coma. It often requires aggressive treatment with corticosteroids, IVIG, or plasmapheresis. Hematologic malignancy. Some patients with scleromyxedema may progress to develop multiple myeloma or other plasma cell dyscrasias. Close monitoring for hematologic malignancy is important. Scleromyxedema is a rare and challenging disorder that requires a multidisciplinary approach for management. Given its systemic nature and potential complications, early recognition and treatment are essential for improving outcomes. Scleroderma is a rare connective tissue disorder characterized by the progressive thickening and hardening of the skin due to the deposition of collagen and mucin in the dermis. Unlike scleroderma, scleroderma does not typically cause Raynaud's phenomenon or significant internal organ involvement. Scleroderma most commonly affects the upper body, particularly the neck, shoulders, and upper back. 1. Pathophysiology, collagen and mucin deposition. In scleroderma, there is abnormal deposition of collagen and mucin in the skin's dermal layer, leading to skin thickening and stiffness. The underlying cause of this deposition is not well understood. Associated conditions. Scleroderma is often associated with systemic conditions such as diabetes mellitus, infections, e.g., streptococcal infections, and monoclonal gammopathy. The disease is categorized into 3 clinical forms based on these associations. Type 1, associated with recent infections, often streptococcal, and typically affects younger individuals. This form may be self-limited and resolves spontaneously over time. Type 2, associated with monoclonal gammopathy, particularly IgG kappa paraprotonemia, and tends to have a chronic course. Type 3, associated with long-standing diabetes mellitus, usually insulin-dependent, and often affects middle-aged to older adults. This form tends to be more chronic and refractory to treatment. 2. Clinical features. Skin changes. Symmetrical thickening. Scleroderma typically presents with symmetrical, non-pitting skin thickening and hardening, particularly on the neck, shoulders, upper back, and face. The skin may feel indurated or woody. Absence of skin tightening. Unlike scleroderma, scleroderma does not cause significant tightening of the skin. However, the thickened skin may limit the range of motion and cause discomfort. Shiny or erythematous skin. In some cases, the skin overlying affected areas may appear shiny or erythematous, reddened. Distribution. Upper body predominance. The most commonly affected areas include the neck, upper back, shoulders, and face. The involvement of the hands, feet, and lower body is rare. Facial involvement. When the face is involved, it can cause a mask-like appearance, although this is less severe than in scleroderma. Systemic symptoms. Unlike scleroderma usually does not involve internal organs. However, patients may experience discomfort and reduced mobility due to skin thickening. And 3. Associated conditions. Infections, type 1. Scleroderma can follow infections, particularly streptococcal infections, and may be self-limiting. It can occur within weeks after an infection and gradually resolve over months. Diabetes mellitus, type 3. Diabetic scleroderma is typically seen in patients with long-standing diabetes, especially those with poor glycemic control. It is more common in middle-aged and older individuals, and unlike the post-infectious form, it tends to be chronic. Monoclonal gammopathy, type 2. Scleroderma associated with monoclonal gammopathy can have a more chronic and progressive course, similar to other paraproteinic skin conditions like scleromyxedema. 4. Diagnosis. Clinical evaluation. Diagnosis is often based on the characteristic clinical presentation of skin thickening, distribution, and associated conditions. Skin biopsy. A skin biopsy can confirm the diagnosis by showing thickening of the dermis with collagen and mucin deposition, along with a lack of significant inflammation. The biopsy can help differentiate scleroderma from other conditions like scleroderma or scleromyxedema. Laboratory tests. Blood tests may be used to evaluate for associated conditions, such as diabetes or monoclonal gammopathy. In post-infectious cases, serologic testing for streptococcal infection may be positive. 5. Differential diagnosis. Scleroderma must be differentiated from other conditions that cause skin thickening, including scleroderma. Scleroderma involves skin tightening and fibrosis, often with Raynaud's phenomenon and internal organ involvement. Scleroderma lacks these features. Scleromyxedema. Scleromyxedema also involves mucin deposition, but is associated with waxy papules, systemic involvement, and monoclonal gammopathy. Lichen myxedematosus. This localized form of cutaneous mucinosis presents with localized papules rather than the widespread skin thickening seen in scleroderma. Eosinophilic fasciitis. This condition involves inflammation and fibrosis of the fascia, leading to skin thickening, but typically spares the hands and face, which are commonly affected in scleroderma. NAR6. Treatment. Treatment challenges. Scleroderma can be difficult to treat, particularly the chronic forms associated with diabetes or monoclonal gammopathy. Treatment is often aimed at managing the underlying condition and relieving symptoms. Post-infectious scleroderma, type 1, observation. Since this form of scleroderma may resolve spontaneously, observation and supportive care are often sufficient. Corticosteroids. In some cases, corticosteroids may be used to reduce inflammation and speed recovery. Diabetic scleroderma, type 3, improving glycemic control. In patients with diabetic scleroderma, optimizing blood glucose control is crucial and may improve skin symptoms. Physical therapy. Physical therapy can help maintain mobility and prevent contractures in affected areas. Phototherapy. Phototherapy, e.g. PUVA, UVB, has been reported to provide some benefit in patients with diabetic scleroderma. Scleroderma associated with monoclonal gammopathy, type 2, treating the gammopathy. In patients with monoclonal gammopathy, treatment of the underlying hematologic disorder, e.g. with chemotherapy or immunotherapy, may improve skin symptoms. Immunosuppressive therapies, corticosteroids, methotrexate, and other immunosuppressive agents have been used in some cases with varying degrees of success. NAR7. Prognosis. Variable course. The prognosis of scleroderma depends on the type and associated conditions. Post-infectious scleroderma often resolves spontaneously over several months to a few years, while diabetic and monoclonal gammopathy-associated forms tend to be more chronic and refractory to treatment. Long-term management. Patients with chronic scleroderma may require long-term follow-up and supportive care to manage symptoms and maintain quality of life. 8. Epidemiology, rare condition. Scleroderma is a rare disorder, and its exact prevalence is unknown. It can affect individuals of all ages, but is more common in middle-aged adults, particularly those with diabetes. Gender and age. The diabetic form of scleroderma, type 3, is more common in middle-aged to older adults, with a slight male predominance. The post-infectious form, type 1, tends to affect younger people, often following a streptococcal infection. Complications. Mobility issues. Skin thickening and hardening can lead to limited range of motion, particularly in the neck and upper body. This can result in functional impairment and discomfort. Infection risk. In some cases, especially in those with diabetes, skin thickening may increase the risk of secondary skin infections. Scleroderma is a rare and often underrecognized disorder that requires a tailored approach to treatment depending on the associated conditions. While some forms may resolve spontaneously, others can be chronic and difficult to treat, necessitating long-term management and support. Lichen myxedematosus, LM, also known as papular mucinosis, is a rare chronic disorder characterized by the deposition of mucin in the skin, leading to the formation of waxy, flesh-colored papules. It falls under the group of cutaneous mucinoses, which are disorders associated with the abnormal accumulation of mucin, a glycosaminoglycan, in the dermis. Lichen myxedematosus is distinct from scleromyxedema, although both involve mucin deposition. Classification: lichen myxedematosus is classified into two main categories, localized and generalized. 1. Localized lichen myxedematosus. No systemic involvement. This form is confined to the skin and lacks systemic manifestations. Subtypes: discrete papular lichen myxedematosus, characterized by small, discrete papules, typically localized to the limbs. Acral persistent papular mucinosis. Papules are limited to the hands and feet. Cutaneous mucinosis of infancy. This rare variant occurs in children and presents with papules that may resolve spontaneously. Self-healing papular mucinosis. This rare form occurs in children or young adults and is characterized by spontaneous resolution. 2. Generalized lichen myxedematosus, scleromyxedema. Systemic involvement. This is the more severe form that involves both the skin and internal organs. It is associated with a monoclonal gammopathy and is considered a distinct entity, scleromyxedema. 1. Pathophysiology. Mucin deposition. In lichen myxedematosus, there is abnormal deposition of mucin in the dermis, which is produced by fibroblasts. The exact cause of this mucin deposition is unknown. Absence of systemic involvement. Unlike scleromyxedema, localized lichen myxedematosus does not involve systemic manifestations such as organ involvement or a monoclonal gammopathy. 2. Clinical features. Skin changes. Waxy papules. The hallmark of lichen myxedematosus is the development of small, flesh-colored, or slightly erythematous papules that are firm and waxy in appearance. Localized distribution. The papules are typically localized to certain areas of the body, depending on the subtype. For example, in discrete papular lichen myxedematosus, the papules are usually found on the limbs, while acral persistent papular mucinosis affects the hands and feet. Absence of sclerodermoid features. Unlike scleromyxedema, there is no skin tightening or hardening, and systemic features such as myopathy, neuropathy, or internal organ involvement are absent. Lack of systemic symptoms. Patients with localized lichen myxedematosus do not exhibit systemic symptoms, differentiating it from the more severe form, scleromyxedema. Diagnosis. Clinical examination. Diagnosis is often based on the clinical appearance of waxy papules in a localized distribution. The absence of systemic symptoms or monoclonal gammopathy helps distinguish it from scleromyxedema. Skin biopsy. A biopsy can confirm the diagnosis by showing mucin deposition in the dermis, along with increased fibroblasts. Special stains, such as Alcyon blue, are used to highlight mucin. Laboratory tests. Unlike scleromyxedema, laboratory tests typically do not show any abnormalities, such as monoclonal gammopathy or systemic involvement. 4. Differential diagnosis. Lichen myxedematosus must be differentiated from other conditions that cause papular skin lesions or mucin deposition, including scleromyxedema. While both conditions involve mucin deposition, scleromyxedema is associated with systemic involvement and monoclonal gammopathy, which are absent in localized lichen myxedematosus. Lichen planus. This condition can present with papules, but they are typically violaceous in color and do not involve mucin deposition. Granuloma annulare. This condition presents with annular plaques, often on the hands and feet, but lacks mucin deposition. Erythema elevatum diutinum. This is a rare vasculitis that can present with papules and plaques, but is associated with leukocytoclastic vasculitis rather than mucin deposition. 5. Treatment. Treatment challenges. Lichen myxedematosus, especially the localized forms, can be challenging to treat. There is no standardized therapy, and treatment is generally aimed at reducing symptoms and improving the appearance of the skin. Topical corticosteroids. These are often the first-line treatment for reducing inflammation and improving the appearance of the lesions. Phototherapy, UVB or PUVA phototherapy, has been used with some success in treating localized lichen myxedematosus. Systemic therapies. In more resistant cases, systemic therapies such as retinoids, e.g. isotretinoin, or immunosuppressants, e.g. methotrexate, may be considered, though their efficacy is variable. Observation. In some cases, particularly in the self-healing subtype, spontaneous resolution may occur without treatment. 6. Prognosis. Localized forms. The prognosis for localized lichen myxedematosus is generally favorable, with no risk of systemic involvement or progression to more severe disease. However, the condition can be chronic and persistent, and recurrences are common. Self-healing forms. Some forms, particularly the self-healing papular mucinosis seen in children or young adults, may resolve spontaneously without long-term sequelae. 7. Epidemiology. Rare condition. Lichen myxedematosus is a rare disorder, with only a few hundred cases reported in the medical literature. It affects both men and women, and the age of onset can vary depending on the subtype. Gender and age. The discrete papular form of lichen myxedematosus typically affects middle-aged adults, while the self-healing form is more common in children and young adults. 8. Complications. Cosmetic concerns. Although localized lichen myxedematosus does not involve systemic organs, the waxy papules and skin changes can cause cosmetic concerns, leading to psychological distress. Chronic course. The chronic and often persistent nature of the disease can lead to frustration, as many patients experience recurrent lesions despite treatment. Lichen myxedematosus is a rare and localized disorder of mucin deposition that generally has a favorable prognosis due to its lack of systemic involvement. Treatment options are limited, and spontaneous resolution may occur in some forms, making early diagnosis and monitoring essential. Hypothyroidism can sometimes mimic certain aspects of scleroderma, and it is important to consider it as a differential diagnosis, particularly in patients presenting with skin thickening or other systemic symptoms. While hypothyroidism itself does not directly cause scleroderma like skin changes, it can lead to various manifestations that may resemble or overlap with those seen in scleroderma. 1. Common clinical features of hypothyroidism that can mimic scleroderma. Skin changes. Dry, thickened skin. Hypothyroidism can cause the skin to become dry, coarse, and thickened, especially on the extremities. This can superficially resemble the skin thickening seen in scleroderma. Puffy face and extremities. Hypothyroidism can lead to generalized myxedema, which causes puffiness of the face and extremities due to mucin deposition in the skin and subcutaneous tissues. This puffiness can sometimes be mistaken for scleroderma-related swelling or induration. Raynaud's phenomenon. Although uncommon, Raynaud's phenomenon can occur in hypothyroid patients, leading to episodic color changes in the fingers and toes. This overlaps with a classic feature of scleroderma, although Raynaud's is much more characteristic of systemic sclerosis. Musculoskeletal symptoms. Arthralgias and myalgias. Hypothyroidism can cause joint and muscle pain, stiffness, and weakness, which might be mistaken for the musculoskeletal manifestations of scleroderma. Carpal tunnel syndrome. This is common in hypothyroidism due to the accumulation of mucinous material around the nerves, leading to neuropathy, which can also occur in scleroderma due to fibrosis or vascular changes. Fatigue and weakness. Fatigue, a common symptom of hypothyroidism, can overlap with the fatigue seen in scleroderma, contributing to diagnostic confusion. 2. Pathophysiology of skin and connective tissue changes in hypothyroidism. Mucin deposition, myxedema. In hypothyroidism, glycosaminoglycan mucin accumulation in the dermis leads to thickened, coarse skin and puffiness, known as myxedema. This is due to decreased degradation and increased synthesis of mucopolysaccharides, causing water retention in the skin. Delayed wound healing. The skin in hypothyroidism can become more prone to dryness and delayed wound healing, resembling some of the skin manifestations seen in scleroderma. 3. Differentiating hypothyroidism from scleroderma. Skin texture and distribution. In scleroderma, skin thickening tends to be more localized and associated with a sclerotic or hardened texture, often affecting the hands, sclerodactyly, face, and distal extremities. In hypothyroidism, skin thickening is more generalized, with a doughy or puffy consistency rather than a hardened texture. Internal organ involvement. Scleroderma often involves internal organs, such as the lungs, gastrointestinal tract, heart, and kidneys, whereas hypothyroidism does not typically cause such widespread organ involvement, although it can affect cardiovascular function, e.g. bradycardia, pericardial effusion. Raynaud's phenomenon. Raynaud's phenomenon is a hallmark of scleroderma, often preceding other symptoms by years. While it can occur in hypothyroidism, it is much less common and typically less severe. Laboratory findings. Thyroid function tests. Hypothyroidism can be confirmed through elevated TSH, thyroid stimulating hormone, levels and low levels of thyroid hormones, free T4. Autoantibodies in scleroderma. Autoantibodies such as anticentromere, anti-SCL70, topoisomerase 1, and anti-RNA polymerase 3 are often present, whereas hypothyroidism, particularly autoimmune hypothyroidism, Hashimoto's thyroiditis, is associated with thyroid peroxidase, TPO, and thyroglobulin antibodies. Histology. Skin biopsy in scleroderma reveals fibrosis of the dermis with atrophy of the adnexal structures. In contrast, hypothyroidism typically shows mucin deposition in the dermis without fibrosis. Round 4. Overlap syndromes. Autoimmune connection. Both hypothyroidism, especially autoimmune Hashimoto's thyroiditis, and scleroderma are autoimmune conditions, and they can coexist. Patients with one autoimmune disease are at a higher risk of developing another, so a person with hypothyroidism may also develop scleroderma, and vice versa. 5. Management considerations. Treating hypothyroidism. If hypothyroidism is diagnosed, treatment with thyroid hormone replacement, levothyroxine, often improves many of the skin and systemic symptoms. This is a key differentiator as scleroderma requires more complex immunosuppressive and supportive therapies. Monitoring for overlap. In patients with hypothyroidism presenting with unusual symptoms like Raynaud's phenomenon or more severe skin changes, monitoring for potential overlap with scleroderma or other connective tissue diseases is crucial. Sick conclusion. While hypothyroidism can mimic some of the features of scleroderma, careful clinical evaluation, including laboratory testing and a detailed history, can help differentiate the two conditions. Thyroid function testing should be a routine part of the evaluation in patients presenting with scleroderma-like symptoms to rule out hypothyroidism as a differential diagnosis. Graft versus host disease, GVHD, is a potential differential diagnosis for scleroderma, particularly in patients with a history of allogeneic hematopoietic stem cell transplantation, HSCT, or solid organ transplantation. Both chronic GVHD and scleroderma can present with skin tightening, sclerosis, and systemic involvement, making it important to differentiate between the two for appropriate management. 1. Pathophysiology, graft versus host disease, GVHD. GVHD occurs when donor immune cells, the graft, recognize the recipient's tissues, the host, as foreign and mount an immune response against them. Chronic GVHD can affect multiple organs, including the skin, gastrointestinal tract, lungs, liver, and eyes. Chronic GVHD often manifests several months after transplantation and can resemble autoimmune conditions like scleroderma. Scleroderma, systemic sclerosis. Scleroderma is an autoimmune connective tissue disease characterized by fibrosis of the skin and internal organs, vascular abnormalities, and autoantibody production. It can present as localized skin involvement or as a systemic disease affecting multiple organ systems. 2. Clinical features of GVHD mimicking scleroderma. Skin changes, sclerosis, and tightening. In chronic GVHD, patients may develop skin changes that mimic scleroderma, including sclerosis, tightening, and hardening of the skin. These changes can lead to contractures and decreased mobility, similar to the sclerodactyly and contractures seen in scleroderma. Lichenoid lesions. GVHD often presents with lichenoid skin changes, small, flat, scaly lesions that are less common in scleroderma. However, in severe cases of GVHD, extensive fibrosis and thickening of the skin can occur, making it difficult to distinguish from scleroderma. Poikiloderma. GVHD can also cause poikiloderma, which is characterized by mottled pigmentation, telangiectasia, and epidermal atrophy. This is less common in scleroderma. Systemic involvement. Lung involvement. Both GVHD and scleroderma can cause pulmonary complications. Chronic GVHD can lead to bronchiolitis obliterans, a condition characterized by inflammation and fibrosis of the small airways, resulting in obstructive lung disease. In contrast, scleroderma often causes interstitial lung disease, ILD, with restrictive lung function due to fibrosis of the lung parenchyma. Gastrointestinal tract. GVHD can cause significant gastrointestinal involvement, including esophagitis, malabsorption, and diarrhea, which can also be seen in scleroderma, though the mechanisms differ. Scleroderma often causes gastrointestinal dysmotility and fibrosis, leading to similar symptoms. Ocular and oral involvement. GVHD can cause severe dry eyes, keratoconjunctivitis sicca, and dry mouth, xerostomia, akin to secondary Sjogren's syndrome, which can also be seen in scleroderma. However, GVHD-related mucosal involvement is often more severe and can include ulceration. 3. Differentiating GVHD from scleroderma. History of transplantation. The most critical clue is the patient's history. Chronic GVHD occurs in individuals who have undergone an allogeneic HSCT or, less commonly, solid organ transplantation. A history of transplantation should raise suspicion for GVHD rather than primary scleroderma. Timeline of onset. Chronic GVHD typically develops several months to years after transplantation, while scleroderma can occur at any point in life without a history of transplantation. The temporal relationship to the transplant can be a key differentiator. Skin distribution and characteristics. Scleroderma, skin thickening in scleroderma typically starts in the fingers and hands, sclerodactyly, and may progress to involve the face, forearms, and trunk. Skin changes are often associated with the presence of Raynaud's phenomenon. GVHD. In contrast, GVHD-related skin changes can be more diffuse and are not typically associated with Raynaud's phenomenon. Lichenoid or poikilodermatous changes are more suggestive of GVHD than scleroderma. Systemic manifestations. Autoantibodies. Scleroderma is associated with specific autoantibodies, such as anti-centromere, anti-SCL70, topoisomerase 1, or anti-RNA polymerase 3. These are generally absent in GVHD, although GVHD can trigger the production of autoantibodies. Lung disease. While both diseases can cause lung fibrosis, bronchiolitis obliterans is more characteristic of GVHD, whereas interstitial lung disease is more typical in scleroderma. GI tract. GVHD may cause more severe mucosal involvement with ulceration and inflammation, while scleroderma is more likely to cause smooth muscle atrophy and fibrosis leading to dysmotility. Laboratory and biopsy findings. Histopathology. Skin biopsy in GVHD may show interface dermatitis with apoptotic keratinocytes, fibrosis, and mucin deposition, while scleroderma typically shows dermal fibrosis with a lack of significant inflammation. Chronic GVHD can also show lymphocytic infiltration in various tissues. Organ involvement. In GVHD, biopsy of affected organs, such as the liver or gastrointestinal tract, can reveal lymphocytic infiltrates and tissue destruction, while in scleroderma, fibrosis and vascular changes are more prominent. 4. Management considerations. Treatment of GVHD. Chronic GVHD is treated with immunosuppressive therapies, such as corticosteroids, calcineurin inhibitors, or other agents like mycophenolate mofetil and rituximab. Treatment aims to suppress the donor immune response and prevent further tissue damage. Treatment of scleroderma. Scleroderma treatment often involves immunosuppressants like methotrexate, mycophenolate mofetil, and cyclophosphamide, along with targeted therapies for organ involvement, e.g., pulmonary fibrosis, renal crisis. 5. Conclusion. GVHD and scleroderma share several clinical features, including skin thickening, systemic involvement, and fibrosis, but they differ significantly in their underlying pathophysiology, associated history, and specific manifestations. A careful clinical history, focusing on previous transplantation, along with a thorough evaluation of the skin, internal organs, and laboratory findings, can help distinguish chronic GVHD from primary scleroderma.